So welcome everyone. This is our last Lunchtime Seminar of the spring, and the program is being streamed live on Facebook, and the recording is also available on our website. So if you know anyone who was not able to be here, they can go on wcwonline.org to watch the presentation next week. We're very excited to have some special guests with us today from our Council of Advisors who traveled to be here as far as Ghana. So welcome and thank you. And today, Dr. Tracy Gladstone will present Preventing Youth Depression in a Digital Age, an Internet-Based Approach. As many as 13 to 20% of adolescents in the U.S. and other developed countries experience minor or major depressive episodes each year. Given the substantial prevalence of adolescent depressive disorders, associated functional impairments, the risk of unhealthy behaviors, and lifelong illness, it's vital that we develop, evaluate, and disseminate preventive programs for adolescent depression. Tracy and her team developed and evaluated a self-guided, internet-based primary care intervention, Catch It, to target teens aged 13 to 19 at risk for depressive illness. And today she's going to share outcome data from the federally funded trial. Tracy Gladstone is an associate director and senior research scientist at WCW. She's also the inaugural director of the Robert S. and Grace W. Stone Primary Prevention Initiatives, which focus on research and evaluation designed to prevent the onset of mental health concerns in children and adolescents. Tracy is an assistant in psychology at Boston Children's Hospital, an instructor at Harvard Medical School, and a research scientist at Judge Baker Children's Center. For the past 20 years, she's focused her research on the development, implementation, evaluation, and dissemination of preventive interventions targeting depression in children and families. Please hold questions until the end, and now let's welcome Tracy Gladstone.
Hi, it's great to be here. I'm going to just push this a little closer. Or can I push it closer? All right, I'll just push the whole thing. Okay. So it's great to be here to talk about this study. A bunch of my team members are here, and I want to just make sure to give them a shout out, people who worked for me, with me on this project in the past and also currently, because it really has been a joint effort over many years. And I have stood up here and talked about this research a number of times, but this is the first time I'm actually telling you what we found. So it's kind of exciting. I'm going to present some 6-month data, and I'll try to explain very bulky slides that come towards the end. But I'm going to first just talk about the problem of youth depression, how prevalent it is, how to recognize it in kids and adolescents. And I know that Megan said questions at the end, but if there is something pressing, feel free to let me know, and I will pause. So adolescent depression has just been really in the news a lot lately. In the past year or two, adolescent depression has been a problem for many years, but now it feels like just in the popular press we're seeing much more about it. We're seeing about issues in as early as middle school and going through high school and even into the college age. Time magazine just a month ago had an article about depression on college campuses, anxiety and depression on college campuses, and how prevalent it is, and how whatever we're doing, we just can't seem to reach all the kids who are needing support. So it's definitely a problem, and definitely needs a lot of attention. At any one point in time, about 3 to 8% of kids will meet diagnostic criteria for a major depressive disorder, but that doesn't mean there's a lot of kids who might not meet diagnostic criteria for depression that are still exhibiting some significant symptoms of depression, and they really need attention. So when you see 3 to 8%, you might think that's not so many kids, but generally about 20% of kids at any given time will report that they're experiencing significant symptoms of depression. And I'll go through what some of those symptoms are in a moment. The lifetime prevalence rate of major depressive disorder in adolescents is about 11%. Some people think it's a little bit higher. The average age of onset is 15. And so prevention efforts, and I'm going to talk about a prevention effort here, but a lot of the literature is suggesting that prevention efforts target kids a couple years before that. So you want to get kids when they're first showing symptoms, give them some skills, give them some support so that they won't develop an onset of major depressive disorder. We know that 40 to 70% of kids will experience a relapse of depression. And I always want to point this out because this, I think, is our best support for focusing on prevention. So if you think about a child at age 15 who might develop their first episode of depression, even if they get great treatment and they respond to that treatment and they're doing really well, within about 5 years, 70% of those kids are going to have a second episode. So even if they're doing better, by the time they're leaving high school, they're starting their next step of life, they're going to be struggling with another depressive disorder. So I just want to briefly go through some of the symptoms of depression. I like to separate them into different categories. I think, if you were looking at criteria in a magazine or in a book, a diagnostic manual of depression, it wouldn't look like this. But this is what I think we see when we see kids out there. We see kids in schools. We see kids in colleges. These are sort of what the psychological symptoms of depression look like. So these are also symptoms of other things. It's not that everybody who shows some pessimism is also struggling with depression. But if you see a clustering of these psychological symptoms, concentration problems, a lot of anxiety, a lot of irritability, especially in kids, you see a lot of irritability as a marker of depression. So kids might not actually look sad. They might actually look more irritable, and that would be of concern. If you see that they're having thoughts of death or suicide, they talk about thinking about hurting themselves, that these can be symptoms of depression. And again, it's not every child who shows these symptoms that I worry about, but when you see a clustering of these symptoms and it lasts for a couple weeks, that's when you're starting to worry. So there's also behavioral symptoms, and you see a lot of these, and I go through these symptoms when I'm talking to teachers and school personnel. What are you looking for when you see a child in your class? And a lot of times kids who are struggling with depression will be really angry a lot. They'll show the inability to manage their emotions. They'll kind of blow up at people a lot. They withdraw. They don't want to engage in activities anymore. They don't want to, if a child who always likes to go to practice, sports practice after school, suddenly doesn't want to go to practice anymore, that's when you worry. And again, it's not that every time a child doesn't want to go to swim practice, it means that that child is depressed. But if you have a child who is showing, a combination of these symptoms, showing that anger, that irritability, that sadness, withdrawing from friends, withdrawing from activities, that's a child that you're worrying about. Physical symptoms. I put this up because a lot of times kids will express their sadness and their depression through physical symptoms. Again, lots of times when kids have a stomach ache, there's really something physical going on, so we can't ignore stomach aches. But a lot of times you see a lot of somaticizing with kids who are struggling with depression, and somehow kids feel that it's more socially acceptable to be having a lot of aches and pains, be unable to get up, a lot of extra sleeping, or difficulty sleeping, heart palpitations, funny burning, tingling sensations in their hands. Those are kids that could be struggling with depression, so you would want to take note of that. When I talk about risk factors for adolescent depression, I like to divide them into specific and non-specific. So non-specific risk factors for depression, well, these are things that are risk factors for any range of disorders. So certainly we know that people who are struggling financially, people who are exposed to violence and maltreatment, people who experience severe life stressors, they're at risk for depression, but they're also at risk for a number of other psychological problems. But then there are specific risk factors for depression. We see much more depression in females than in males, beginning in adolescence and moving on through adulthood. So in childhood, it's more equal rates. Some people even suggest among children that there's more depression in boys than girls. But by the time people reach adolescence, it's about 2 to 1, females to males. We see a lot of people who are struggling with depression. Risk factors for depression we see are genetic. So certainly if there is depression in your family, you're at increased risk for experiencing depression yourself. This is not to say that all people with a depressed parent are doomed to become depressed. Most people with a depressed parent do absolutely fine. So it's not that it's a sure thing that you're going to struggle with depression, but certainly if you have a family loading for depression, then you are more likely to experience it yourself. There are also protective factors, and I wouldn't want to leave these out. Certainly people who show strong problem-solving skills, people who have close family relationships, close community relationships, that kids who are involved in hobbies and activities outside of the home, that are connected to adults outside of the home, these kids are doing better. So there certainly are protective factors, and certainly in intervention programs, you want to build on these protective factors to keep kids healthy. Consequences of adolescent depression. So I mentioned already that children who experience an episode of depression are much more likely to have subsequent episodes over time. But there's also just short-term and long-term consequences of depression. Certainly in the short term, kids who are struggling with depression have more difficult family relationships often. They often don't do as well in school. They often are at increased risk for substance abuse, increased suicidal behavior, suicidal thinking. These are sort of short-term consequences. And then, of course, there's longer-term consequences. So we know that people who struggle with depression during adolescence, that they have repeated episodes, and they also have more psychiatric and medical hospitalizations. They don't do as well at work. They don't do as well in their relationships. So I put this up to talk about depression and suicidal behavior. I really want to highlight that adolescent depression and adolescent suicidal behavior are distinct phenomena, and certainly not all people who struggle with depression are also experiencing suicidal thoughts and engage in suicidal behavior, and certainly not all kids who are thinking about suicide are also depressed. But there is a lot of overlap. So we do know that suicidal thinking is a symptom of depression. We do know that youth suicide is a tremendous problem. So a lot of times when we're focusing on treating depression or intervening, preventing depression, we at least want to be aware of these connections. So why prevent adolescent depression? So a lot of the efforts out there, and if you look at a lot of federal dollars, they're most often going to the treatment of mental health disturbances and mental health problems. And why do we treat mental health problems? Because they're already there. People are already suffering. And so it's easier to see the utility of focusing on treatment. Also, if you just look from a financial perspective and you look at the way our healthcare system is set up and insurance reimbursements are set up, now that there is so much job movement and people change insurance companies so often, there's actually often less of an impetus for insurance companies to fund prevention efforts because the chances of them actually paying to treat people who develop the disorder over time are lower because that person is now being covered by somebody else. But there are a lot of really important reasons to focus on prevention. We know that waiting for a disorder to emerge and trying to treat it can be difficult. We know that there are high relapse rates even when kids are treated for depression successfully. And we also have evidence that there are some very good prevention programs out there that actually can work. And certainly for youth depression, there is evidence now that there are programs that can really stave off the onset of a depressive disorder in kids. So what is Catch It? So Catch It, and I have what it is down at the bottom because I can't ever remember, but you can read it. It's a long name, but it's a web-based program that is designed to support kids and help kids to develop skills, manage life stress, manage negative events, and essentially develop the skills they need to stay healthy. So it targets kids who are at risk for depression. It uses design elements, interactive components to engage kids. It teaches standard evidence-based approaches to depression prevention, including behavioral activation, which is activity scheduling. So understanding the connection between your thoughts and feelings, that's more cognitive behavioral approaches, and then interpersonal psychotherapy approaches, so understanding that the way that you behave with other people influences your mood, and that you could be taught ways of engaging with people more in a better, healthier ways to engage with people. And the Catch It also includes a parent intervention. So why address, I'm sorry, I didn't also mention that it's based in primary care. So it was developed to be used in the primary care setting. So why address depression in primary care? There's a lot of words on this slide, and really the main point I want to make is that we have evidence that kids do well when you embed mental health treatment in the primary care setting. So if you think about how to access kids for prevention efforts, these are kids who are doing pretty well, right? So kids who are already exhibiting signs of depression, are already exhibiting a depressive disorder, they need treatment. But where do you access kids who are not already presenting for treatment? Well, you find them in schools and you find them in primary care. And there is evidence that embedding treatment programs for mental health concerns in the primary care setting can actually work quite well. There's less evidence for the benefits of embedding prevention programs in primary care, but certainly there's a need for prevention efforts in primary care. For something like youth depression, which is such a prevalent problem, so many kids who are struggling are presenting to their pediatricians. We know that about a quarter of all visits for pediatrician visits are for mental health and behavioral concerns. So kids are going to their doctors and giving doctors some tools to help keep kids who are teetering but not yet showing a full disorder. It's a good place to begin. So why a technology-based approach? So we performed a rapid review of internet-based interventions for youth and found essentially evidence that these programs can work well. There's not a lot of literature out there on long-term follow-ups, but there's definitely the sense that you can engage people on technology-based interventions and you can bring about positive change, especially when these programs include some human contact. So if you just pop somebody on a computer and you try to get them to lose weight or try to get them to stop smoking, it doesn't work. But if you can put somebody on a computer and they can also meet with somebody, they have a person that they're accountable to, then these programs seem to work much better. So what we aimed to do with developing Catch It was to develop a program that could be accessible to kids, that could be affordable, that could be private. So I think, with mental health, we all know that there's a lot of stigma surrounding mental illness and a lot of stigma surrounding depression, and developing a technology-based program that could allow people to quietly, privately access an evidence-based program seemed like a target we were going after. So what we aimed to do in developing this intervention was to merge primary care and internet-based approaches. Make a program that's simple and easy to use, consumer-friendly, that includes that motivational component that I mentioned, that person-to-person contact that boosts the effectiveness of internet-based programs, that's user-centered with the safety infrastructure. And that's what we tried to develop in Catch It. So we conducted a pilot study of the Catch It intervention, and the pilot study was looking at 2 different levels of engagement. So all kids, we had about 83 kids, and I'll show you what the sample looked like in this pilot study. All of the kids got the Catch It intervention, but they got it with different levels of engagement by their primary care doctor. So half of the kids randomly got brief advice, which means the pediatrician sat down with the kid and said, you might be depressed and you should try this program. Then the other half of the kids got a motivational interview, and this was really to test how much, what the benefits are from involving human people and getting people on a computer. And so the motivational interview was a bit longer, not really an intense program, not a long interview. They were about 6 minutes. I'll show you how long they were. And basically it was a pediatrician sitting down with a child and saying, you seem to be sad. What are your goals over the next year? And the child will say, I want to get into a good college, or I want to be captain of my sports team, make the varsity team. And then the pediatrician saying, so how do you think your symptoms of sadness are interfering with your ability to reach that goal? And there's this program that if you spend a couple hours on this computer program, it could help you to maybe reach your goals, and what do you think about it? And helping the child work through their resistance when the child says, oh, I don't have time for anything. And then the pediatrician saying, well, if you spend just a couple hours over the next couple months, it could really help. So trying to work with the resistance and help the child to find internal motivation for using the program. Again, these are very, very short, these motivational interviews. We trained the pediatricians to do them, and the pediatricians did pretty well. They had a script, and it wasn't nearly as arduous as the doctors had feared it would be. The parent piece was, we had a parent booklet, so it was not online, and it basically reviewed the symptoms of depression, reviewed the intervention, helped parents to know how to identify when to be worried about their child, and how to promote resilience in their child. So this is the pilot study that was a foundation for the study I'm going to tell you more about. This is what the sample looked like. So for the pilot study, kids were 14 to 21. So we used kids through college, and it was a relatively diverse sample. This just gives you a sense. As I said, the motivational interview was only 6 minutes in length, so it was not a really long interview versus just under 2 minutes. And so you can see the time that the doctor spent with the kids was different. You can see that the percentage of people visiting the internet site was equivalent. So there was no statistical difference in whether the kids had the fuller interview from the pediatrician or the shorter brief advice, they were just as likely to visit the website. But the kids who had the motivational interview actually spent longer on the website, and they typed in more characters. So by typing in characters, that's really our best measure of engagement. So essentially, the kids are asked questions on the website. They're asked about their goals. They're asked about their mood, to monitor their mood, and they type in answers. And so this would suggest that even though they're all visiting pretty equally, they're visiting the site, that they're more engaged in it if they get the motivational interview. If you look at depressive symptoms in both groups, there's no difference. So the symptoms of depression dropped over, I think I'm showing you 2 years of data here. They dropped pretty equivalently for kids in both groups. But if you look at depressive episodes, now we did not diagnose the depressive episodes ourselves, but this is a signal. So basically we asked kids if they had been diagnosed with depression, and kids who got the motivational interview were less likely to be diagnosed with an episode of depression than kids who got the motivational interview. I think I said that wrong. But the motivational piece seemed to have fewer episodes of depressive disorder. So based on this, we decided to do a randomized trial of this intervention against a health education control intervention to see if kids who get the Catch-It program are going to do better overall than kids who do not. And we used, as our active condition, we used the condition with the motivational interview. Because we had some evidence that kids who got the motivational interview spent more time used it more actively and maybe had fewer depressive episodes, we decided to go with that more intense version of the intervention and compare it against a health education control. And I'm going to show you I'll show you what the different websites look like. We included an online parent intervention this time. And we showed the same, we targeted the same behavioral activation, interpersonal psychotherapy, and cognitive behavioral skills in the intervention. So the intervention was updated to look a little bit better. We worked with web designers to make it a little bit more appealing to kids, a little bit less boring. But it was the same intervention. Okay. And what we hypothesized was that relative to the kids who got the health education control, kids who got our active intervention would be less likely to experience an episode of depression over time, and also less likely to would also experience fewer symptoms of depression over time. So that's what we were going for. This gives you a sense of our study design. So the intention was to screen kids in primary care, to have every child who came into primary care practices fill out a 2-question screening form, and then based on their answers to that, if they endorsed any symptoms of depression, we would do a phone assessment to see if it seemed like they would meet criteria. We'd bring them in for a baseline assessment, and the goal was to enroll 200 kids into the active, 200 kids into the control across Chicago and Boston, assess the kids over time, through diagnostic interviews and also self-report measures. And hopefully we were going to find that the kids who got the Catch-It intervention did better. We enrolled kids from a bunch of sites in the Boston area and in the Chicago area. This just gives you a sense. I just want you to realize the trauma of enrolling for this study. It was really, really, really rough. We were wide-reaching and where we went. This shows you the 2-question screener that we used. So the idea was that all of the practices were going to give this screener out to every teen who walked into their practice, and that just didn't happen. And it didn't happen, I think, in large part because it was a paper form at a time that a lot of primary care practices were switching over to the medical record system, and so they didn't want more paper. The HIPAA laws were just coming into effect when we were screening for this, and so they didn't want to pass information to us about kids who scored high, who circled a yes on this form. It was just more for pediatrician practices to do, and they just didn't want to do it. So we ended up being kind of creative in how we recruited kids through primary care still, but we did a very significant letter campaign where we sent thousands of letters to all people on a primary care panel, all patients, all teenagers that went to a certain practice. We sent letters out that the pediatricians actually signed that told them about the study and invited them to contact us if they were interested. So we got kids both through the screeners and through this letter campaign. The kids that we enrolled in the study were 13 to 18. So this is going to be a really important part when I'm talking to you about the data, that we enrolled kids that were high risk, and we identified kids as high risk based on 2 factors. So they could be determined to be high risk if they exhibited current symptoms of depression, so elevated scores on a self-report measure of depression, or they could be enrolled and determined to be at risk if they had had a past episode of depression, but were doing fine now, or both. So 2 ways to get kids. So that means that a portion of our kids did not exhibit any current signs of depression. They seemed to be doing fine, but they had had depression in the past, and so they're considered at risk. We know that kids who have had an episode in the past are more likely to have subsequent episodes, and they were enrolled. And then there were a number of kids in the study that also came in symptomatic. If kids were currently depressed and they currently met criteria for major depressive disorder, they were excluded because they needed treatment. This was a prevention study, so we did not enroll kids who were currently depressed. We also did not enroll kids who had a history of cognitive behavioral psychotherapy, manual-based cognitive behavioral psychotherapy, because if we did enroll those kids, we wouldn't know if they were using the skills they had learned from that previous treatment or if they were using what they were learning on the web-based program. We didn't enroll kids with current significant drug or alcohol abuse, and that's because the literature suggests that kids who are using substances significantly are less likely to benefit from this type of intervention. So we didn't want to enroll those kids. And we did not enroll kids with current significant suicidal ideation because, again, those kids needed more monitoring, they needed treatment, and this was a prevention trial. Okay, so that's all clear? Okay. So this gives you a sense of what the dashboard looks like for the Catch It intervention. I can tell you that we did a lot of work with focus groups to get a sense of what kids would find appealing. I stood outside the high school that my kids went to and actually had pictures of different possible designs, colors, designs. It was really good we did that because what we thought was awesome, the kids did not. And this is what the kids liked. And so this is what we used. I should mention that it's text heavy. I'm going to show you also what a page looks like. The program was text heavy. And I think when you're doing web-based programs, you always and really any program, you always encounter this, you have to balance between sort of a game, especially on a computer, like a game kind of program or a program that's some work. And there are definitely interventions out there and web-based interventions out there that use a more gaming approach. And I think from our end, first, we had evidence from our pilot study that this program works. So we didn't want to shake it up too much. We wanted to kind of stick with what we knew worked. And also, when you start with gaming on a web-based therapeutic program, the gaming industry moves so much that it's really hard to keep up with them. It's hard to keep up. If you're trying to make something that's going to be really appealing to kids, you're kind of going to miss it if you're going in the gaming way. So that's another reason why we went this route. This gives you a sense of this is sort of the start to the cognitive behavioral section. And then I wanted to highlight this because we also had video blogs. This is one of my favorite parts of the program. So there were 6 kids that we had they did a video diary. So there was kind of a description of something going on in their lives, and then they would actually talk about their experiences, and the content of these video blogs matched the content of what the chapter and what the module in the intervention was focusing on. And really we tried to use a range of kids with a range of issues so that there would be somebody that appealed to anybody who's using the intervention. And we did have definitely some kids who would just kind of page through and just go to this page and watch all the videos. And then we had some kids who would actually just follow a certain person that really resonated with them. This was a health education website. It was designed to be really boring, and it is really boring because we really didn't want it to be too good. We didn't want it to compete with the program, what we thought was the active condition. And it's an interesting, even just ethically, it's hard to know the approach when you're doing research on this type of program. there is a school of thought that says that for prevention research, you shouldn't even need to have a control intervention. But we had to. NIMH demanded that we had a control intervention. So we really focused on developing a program that would give some information that could be useful based on the kind of the well child visits. You go to the pediatrician and you have, and you get a slip of paper every year. You go to a pediatrician, bike helmet safety or whatever they give you. We try to kind of mimic that on this website. This shows you how boring it is. For whatever reason, they loved it. So I'm going to tell you about that. Unfortunately, they loved the control intervention as well. So the revised parent program, so I said it was online. We included videos, just like there were the video blogs for the kids. We had videos for the parents. We included skill builders for the parents, mood monitoring for the parents, and this gives you a sense of what the content of the modules was. It was very similar to the parent program that was in the original study. The parents from the original study said, we want an online program too, so we put this online. We also included a module, what to do if you think you might be depressed yourself. Since we know that there is such a correspondence between adult depression and depression in kids, we wanted to give parents some information to take care of themselves as well. The parent health education website was equally as boring as the kids. We talked about nutrition, vehicle and bike safety measures, snacking, and your routine at work. The last module for the kids of the health education did talk about mood. So this gives you a sense of our sample. So we did send out over 30,000 letters, and that was a lot of stamps. It was a lot of sealing letters. We also collected thousands of those 2-question screeners that we gave out in primary care practices. We evaluated thousands of kids on the phone. We enrolled 443 kids. And then we popped out a number of those kids because we found after we consented the kids to participate in the study, we found that they did not meet our eligibility criteria. We did a really good job of screening those kids out on the phone before we brought them in, but there were some kids that we just missed. Sometimes it was because kids, when they would sit face to face and fill out a self-report measure, they would acknowledge that they were doing more drinking or drug use than we thought, and so then we had to pop those kids out because we didn't want to include kids that weren't really primed to benefit. Sometimes we thought a child, in talking to them on the phone, we thought that they actually had a subsyndromal depression. They weren't depressed, but then when we actually met with them, we found that they already met criteria for depression. They really needed treatment, so we didn't want to enroll them. So we ended up popping out a bunch of our kids. We randomized 369 kids, and the sample is Chicago heavy. So Chicago certainly enrolled a lot more kids than we did in Boston. Those of us who were actively involved in enrolling kids from my team that are back there know how difficult it was to get these kids in Boston, I think in large part because, I'm a psychologist out at Wellesley College, and my co-PI in Chicago is the chief of pediatrics at the University of Illinois Medical Center, and he has a clinic, and he says screen, and they screen. So they did enroll more kids in Chicago than we did in Boston, but we still got 122 kids here, which way proud of those kids. All right, so this is way too many words on this. I recognize that, but I just want to highlight that there were some site differences at baseline that I want to just highlight for you all. So the Boston parents on the whole were older. The Boston kids came in with lower symptom scores than the Chicago kids, lower depressive symptom scores, and that's in large part, so the Boston kids are more likely to have had a past episode of depression, but not have current symptoms, or have lower level of current symptoms. They were less diverse, but still, only 63% of our Boston kids were white. So we did have a good bit of diversity in our sample. It wasn't that we had all of the very high SES white sample, but they were less diverse than the Chicago sample. The Boston parents are more educated. Boston parents are more likely to be married. Again, I'll just tell you what to focus on. There were not demographic differences at baseline by group. So that means that the kids who got the active condition, the catch-it condition, versus the kids who got the health ed condition, there were no real differences. And only about half of the fathers across site had a college education. So it was a bit of a mixed sample. Sample risk at baseline. So this is what I had explained to you, that some of our kids came in with just elevated symptoms. Some of our kids came in with just a past history, and some of our kids came in with both. And about 40% of our sample had a past episode of depression. And that was higher in Boston. So about 50% of the Boston kids had a past episode, and about 36% in Chicago had a past episode. And we followed up with about 85% of our sample, which, given that it was a relatively diverse sample over time, we feel pretty good about that. Our follow-up rates were a bit better here in Boston, so I have to brag. Okay, I have fewer kids, but they did follow. They did come back. We were better at that. This also gives you this gives you a sense of dose, how much time they spent on the computer, and if you look at and these were significant differences. So if you look at the amount of time kids spent, the orange bar is Catch It and the blue bar is Health Ed, and kids spent a lot more time on the Catch It intervention than they did on the Health Ed intervention, and parents spent more time on the Catch It intervention than they did on the more boring Health Ed program. And this gives you a sense, again, remember, this is kind of the best marker of engagement with the program. And again, I want to take every opportunity to brag about my kids because there were fewer of them. And they did actually spend more time on the web-based programs than the Chicago kids. So if you look at the number of characters they typed in, I'm sure you don't remember the other slide during the pilot study, but they actually were much more engaged in this version of Catch It than they were at the pilot. Okay, so this is across sites. Across groups. So this is across sites and across groups. Okay, at 6 months, baseline to 6 months, everybody's symptoms of depression decreased. So no group differences, everybody's symptoms decreased over time. So that means being in a study like this, being in a program like this, having the assessments that they had, kids who used the active version or the control version, all of them showed a decrease in their depressive symptoms, and all of the kids across site and across group showed an increase in their GAS scores, which is a measure of functioning. So it's an assessor-rated measure of functioning. So the other one, the CSD, the depressive symptoms, is a self-report measure of symptoms. This is an assessor-rated measure of their overall functioning. So after talking and doing an interview, assessors said that the kids in both groups were doing better over time, but no difference by group. Okay, this gets confusing, but I'm going to just walk you through a couple things. What I really want to focus on here is that across groups, incidence rates for depression were much lower than we would have expected. So if you think about the primary outcome that we're looking at is sort of a sub-threshold depressive episode. Okay, so kids who are really teetering, really close. And what we found is that we would have expected in a general sample of kids, you would expect 15.8% of the kids over 6 months would experience an episode of depression, episode of subthreshold depression, like close to being depressed. You'd expect 15.8%. And in a high-risk sample like ours, you would expect 30%. Okay? So if you look at the annual incidence up there, the top right, 22.99 and 13.83, that's showing you that over 6 months, we had 22.99% of the health ed kids and 13.83% of the Catch It kids exhibited a depressive, what looked like a depressive episode. Okay, so these numbers are less than you would expect in the high-risk sample that we had. Again, this suggests that everybody who got this program, who participated in this study, whatever condition they participated in, everybody did better. And so the overall incidence rates were lower. And what that also means is when you have fewer episodes of depression emerging than you would expect, then you have to have a lot of kids to have enough power to detect differences, significant differences. Okay? And so suddenly our sample size, which was based on this rate of 30%, what you would expect, a 30% rate of depression in high-risk kids, our sample size was now not, it was harder with our sample size to find a significant difference. So even though it looks like many more kids in health ed are showing depression at 6 months, 22.99 versus 13.83, that is not statistically significant. Okay, that difference is not. But if you go down a little bit, okay, so we looked at our outcomes in we sliced it 3 different ways, okay? So intent to treat is sort of the most stringent, that we had 369 kids. That was everybody who was randomized. And you see that that's not statistically different. As treated, I can't really point, but this box here, that box there, those kids, that is any kids or families where a parent or a kid ever clicked on a website, okay? So that was 294 of our kids. And here you can see it's also not statistically different, but you can see the difference is getting a little bit greater, right? And then if you look at the per protocol 2, and you look there, that means that either a parent, it means a total use of 10% of the program. So it could have been that the parent did 2 modules of theirs. It could be the kids did 2 modules of their 14. Or it could be that the parent did 1 and the kid did 1. But if anybody in a family did just 10% of the intervention, that difference is statistically different. It's statistically significant. And I'm going to show you how that looks. So if you look at this graph, the blue line is Catch It, the red line is Health Ed. You want your outcome to be up at the top, right? Because that means it's a survival curve, so it's a probability of out to 6 months surviving without having an episode of depression, okay? And so you can see this is the entire intent to treat sample, the entire 369, and you can see that while it looks like the kids in Catch It might be surviving a little bit better, the red line's a little bit lower towards disorder, it's not statistically significant there. And if you look here, as treated, this is anybody who clicks even once, you can see that the lines are diverging a little bit, but it's still not statistically significant. But if you look at the per protocol 2, this means 10% of the program. So if 10% of anybody is doing 10% of the program, then we do have a statistically significant difference. So it means that the kids who are getting Catch It versus the kids who are getting the control intervention, if they're doing the bare minimum, you find a difference. That the kids in Catch It are less likely to become depressed over 6 months than the control kids. The other thing I want to share with you is looking at the connection between how kids enter, what the measure of risk is, and how kids are responding to the intervention. Okay, so if you remember, I mentioned to you that some of our kids came in and they didn't have elevated symptoms of depression, but they had had a past episode. Okay, so what this shows you is a breakdown, the number of kids that at 4 different cuts of this measure of depressive symptoms. Okay, so the 0 to 5 means they really had no meaningful depressive symptoms at all. So those were the kids who got into the study that had a past episode. 6 to 10, the cutoff was 8, so that half of those kids are kind of the kids who weren't really symptomatic at all, and then they're getting more symptomatic. And then the 11 to 15 and greater than 16, those are much more symptomatic kids. Okay? So it just gives you a sense of the number of kids in each group. And I think this is a really exciting slide, because this shows you that essentially that in the Catch It intervention, there were no differences in survival, in staying healthy for kids regardless of what they came in for symptoms. Okay, so if kids came in with no symptoms or kids came in with high symptoms, if they got the Catch It intervention, they were pretty likely to do okay over time. But the picture on the right essentially shows you that purple line that's showing you quite a lot of onset of depressive episodes. Those kids are the kids who came in with the highest symptoms. So in the health ed program, if you come in with high symptoms, you're much more likely to become depressed. And these are all significant outcomes. And this is for the entire sample. This is not for the per protocol 2. This is the whole intent to treat sample. And we do find that essentially, if you come in really symptomatic and you get the Catch It intervention, you're pretty likely to stay okay. And I think it's a really important finding, because what it tells us is that if you had a program like this available in pediatric offices, and a kid came into a pediatrician's office and was symptomatic, was exhibiting signs of depression, that if you pop them on the Catch It intervention and they spend, if you remember the amount of time people are spending on these interventions, they're spending an hour or 2 on these interventions over time, and that if they spend just a couple hours on the intervention, that they are quite a bit more likely, significantly, to stay healthy over 6 months than if they don't get the program. So, what are preliminary conclusions? Teens in both groups seem to experience fewer symptoms of depression and better functioning over time. And that's what those pictures that I showed you, that kids in both groups had lower symptoms and higher functioning 6 months after they started. We also found that across groups, the rates of probable or definite depressive disorder were lower than we anticipated. And that really suggests that having a kid in a program like this, in a research study, having a kid who's having their mood monitored over time, who's meeting with kind assessment people on the phone to see how they're doing and checking in with them, who's told that if you get onto this program, you might do better, that those kids do better. Their symptoms go down, their functioning goes up over time. But we also find that across 6 months, for teens who, with their parents, complete a total of at least 2 modules, which is a really low bar, it's 2 modules of the whole program, that Catch It is associated with fewer episodes of depression than the Health Ed program. So you have to do something on Catch It to get a benefit from it. And we also found that over 6 months, that Catch It appears to be associated with fewer episodes for kids with higher levels of depressive symptoms when they enter. Okay, so it might be that for kids who, if you have a child come into a pediatric office and they have no symptoms of depression, but they've had a past episode, they aren't really going to make any better use of Catch It than they are of the control intervention. But if you have a kid who's symptomatic, giving them this program could really help them to stay healthy. So, extending our findings, so this really suggests that pediatrics can act as a gateway to a well-functioning health system if doctors are properly trained to screen and refer kids, and if referral resources are available. We also know, and this is a really important point to make, that delaying the onset of treatment for a child who is symptomatic can really decrease overall how they're doing over the long term. So some of these research studies, we find there were research studies out there with waitlist control conditions where they'll give an intervention to kids who come in who are symptomatic, and then they'll hold off for 6 months. And what we find is that even if you then give them the intervention, the active intervention, you hold them off, they're going to do much less well over time. So giving them something like Catch It could actually fill that gap. It could be a program that if a symptomatic kid came into a primary care office, you could give them this web-based program, send them off, do a little interview with them, and after 6 minutes, interview with them and send them off to use this program. And even if even over time while you're trying to connect them with other services, if they actually need treatment, this could be something that can hold them off from developing a more significant episode, and it gives them something to promote positive mental health. Large-scale implementation. So this program has been implemented successfully in China. We've also been working on an intervention for Arab youth. That paper's in press. It's been adapted for use, urban minority youth in the Chicago area. We have a grant application and now trying to get funding to use the intervention to look at the intervention relative to another group-based cognitive behavioral intervention that could be embedded in primary care, to look at patient satisfaction and what people are willing to engage in for prevention. It's hard when somebody does not have a disorder. It's hard to get them to engage in a prevention program because they don't view themselves necessarily as ill. So looking at different degrees of involvement on different interventions. And we're also looking at adaptations for LGBT youth and looking to create actually a sibling version of this intervention that kids could actually, from a drop-down menu, choose what program they wanted, but adapting it for gender and sexual minority youth, given that is a particularly vulnerable population. I just want to give you a sense of feedback because people really, the teens really loved the program on the whole. The parents really loved the program on the whole. We really didn't have a lot of complaints. Sometimes there were technological problems using the program, but on the whole, people were very happy with it and really liked to have something that they could do for their kids when they knew that their kids were sort of teetering and they didn't really know how they were going to support them. So that's it. So questions, please. Well, at this point, it's not, it's just in sort of development. So, the idea for a program like this is that it really is from a public health perspective. But the idea is that it can be rolled out broadly for very little cost. The cost of the motivational interview has to be figured in, and it is 6 minutes of a pediatrician's time. And a pediatrician, you can get a script, and but it does take a little bit of primary care time to do that piece.
How do you suggest this to a primary care?
How do you get them involved?
Yeah.
So it's a really interesting problem, because I think a lot of primary care doctors, when we approach them initially about even just being involved in this research study, they're like all over it, because they have so many kids that they're worried about and they don't know what to do, and they're afraid to ask kids how they're doing. They're afraid to screen kids because they're afraid if a kid says that they're really struggling, they wouldn't know what to do. They couldn't find referral resources. It's such a tremendous problem. So pediatricians are really on board when you initially suggest it, but then the reality is when they realize that they have to actually learn the motivational interview, even though we gave them a DVD so they could like look at it, to make it as easy as we could. They didn't have to actually talk with us. They could just watch the thing. It's just hard. It's hard to get people to engage in it. I think, my sense is that as these data roll in, and we're just now looking at our 12-month data, which is pretty much showing the same patterns, my hope is that as the data roll in to support a program like this, and as I think like the GLAD PC guidelines, like new guidelines came out from the American Academy of Pediatrics just about a month ago that really focused on embedding programs like this in primary care and focused on the importance of primary care doctors really stepping up and helping these kids. My hope is that there will be sort of a push from a public health perspective to embed this kind of program in there. The cost for it's a website.
Yep.
So it's not that it's a high cost thing, and the idea is that you can take a relatively low level intervention and give it to lots and lots of people and have sort of a broad public health impact, and that's what we're aiming for.
Maybe you mentioned this, or maybe you just remember to include it. How are your outcomes different based on SES and race ethnicity, given health disparities for these populations?
At this point, we don't have any differences. So, I told you the kids coming in were different, but we haven't looked at it as fully as we need to look at it because these are kind of new data, but nothing is screaming to us at this point. And we were careful to make the website accessible to a range of people. So far, they're not there. Anything else?
I'm curious, was 10% participation a high level of participation?
That's a really interesting, it's an interesting question. I think the reality is, again, the Boston kids use the internet a lot more than the Chicago kids. We had 245, I believe, was the N for two modules or more.
Okay.
So 245 out of 369 kids use that much, or kids or parents use that much of the intervention. What we generally found is that there were some people who were like groupies, and they used the whole thing, and the parents used the whole thing, and they were like, woohoo, this is awesome. And then some people who never got onto the website at all. And so that's what, I think that's part of our job now, is to figure out who's using it and who's not, who's benefiting from it and who's not. And those are some of the, the moderator analyses that we're in the process of working on now, because ultimately you'd want to make it more accessible to everybody.
So, I'm actually, asking about,
Mhm.
because that was a significant difference point. Are you saying that a minimum use of 10% produces significant, but a greater use, does that produce a more significant difference?
So I didn't put this up because we don't have our heads fully around it, but I'll just give you a preview.
Okay.
That we definitely have some suggestion that there is a level at about 5 modules, even out to a year, that at about 5 modules that the kids who are using the catch and intervention versus a health ed, over and above the effects of using the health ed, are doing better.
Oh,
So you really need to put in, you need to actually give it some time. You really need to have
Sure.
some investment, and that would make sense. If you don't go to therapy, you can't really expect to benefit from therapy. If you don't use a program, you can't really expect it to work for you. And it seems like 5 is sort of the tipping point.
Were these websites accessed to desktop versus mobile? Do you see anything with that?
So this is one of these things when I said like that the technology field moves faster than we do. This intervention was only available on computers. For our next versions, we've included in our budget to get it onto phones and tablets, and we know that it needs to be accessible in those ways, but this version was not. And actually, that was when when people tried to get on a tablet, when people would try with a different browser, there were technological issues. We recruited for this study 5-6 years ago, and that's a lifetime in the world of computers.
So it's clear that human intervention makes a difference in the success of the program and the use of the program. It wasn't clear to me, as kids and their parents are using the program, when do they get assessed? When do they have their first, second, third, whatever intervention with a human being, which might, of course, boost the efficacy of the program?
So for the motivational interviews, that's the talking with the pediatricians. They were scheduled at baseline, like before they got onto the computer. 2 months later, the idea being that most kids will pretty much do what they're going to do within 2 months, and then a year later. So there were 3 motivational interviews, and then our assessment points were standard: 2 months, 6 months, 12 months, 18 months, 24 months.
So there was actually a lot of interaction with a human being.
So we were really careful. So one of the reasons why we did all of the assessments beyond the initial baseline assessment were done on the phone. And we did that to really minimize the kind of non-specific therapeutic effects of assessments, but certainly those, and I think that's when we see that our overall rates of illness are so much lower than we thought they would be, because there are those non-specific effects that I think when you're in a trial like this, then you definitely benefit from that attention, from having, meeting with your primary care doctor and having these phone calls all the time, and the parents got a phone call and the kids got a phone call, and that's just part of the research problem. It is a research issue, and one of the, we struggle even in planning future studies to decide, if we just did self-report measures, we could do it all on the computer and not have phone assessments, and that could minimize some of it. But actually the data suggests, and we see it here in what I just shared with you, that the group differences don't emerge on symptoms of depression, they emerge on diagnoses. And really looking at diagnostic patterns, that's sort of the gold standard for prevention research. People's symptoms fluctuate a lot. So when really at any given time, people could be having a better day or a worse day. And if you really want to look at episode and illness prevention, you have to do diagnostic interviews, and that requires person-to-person time, and that's why we try to do it. I mean, I can't say that I told people to be mean on the phone, but you have to, trying to keep a little bit of a distance with people that we were assessing, just to try to minimize those effects, but they certainly emerge.
Did you, as one tree did, what was the literacy level of the website text, and have you thought about its adaptability for lower literacy communities?
Absolutely. So we definitely, I think in one of these slides I mentioned that it has been adapted for urban minority youth, and we definitely it was made at a 6th grade reading level, which is not so low. That's, and it's very text heavy, and we're very aware of that. It's a text heavy intervention. And so we did not have reports from our sample of people having difficulty with it, but certainly that could be one of the reasons why people didn't use it as much, is that it was work. And I think, I want to stress that the intervention is work. And I think that part of this is, if you want to lose weight, you can't just one time eat a salad. Like, you have to really work at it, right? And so I think that part of this is that, when we did go with a text heavy model, we knew that people were going to have to work at it, and it is a lot of work. I do think that you bring up an important point, though, and I think that in newer versions of it, we'll have to vary that as well. Mm-hmm.
Are you going to be able to collate the data from the different groups that you're working with, or are they not comparable because you altered the study?
I'm sorry.
Well, you said you're in China?
Oh, yes.
And you're in lower income
Yes.
areas?
So, yes. Are we going to be able to put it all together and
Yes,
kind of look at the
exactly.
intervention overall? Absolutely, but we're not ready yet, because we're just, we're still actually pulling in our 2-year data from our last kids from this trial. There were some differences in the Chinese trial. They didn't do diagnoses, they just did symptoms. They did have group differences in symptoms that we didn't get, so we need to understand some of those differences. And certainly, like, even the Arab adaptation that we've been working on, the cultural pieces are so huge. There's just so many variability, so many variants of the program, but absolutely, we do need to write an overall thing that looks at the intervention.
You'll try to control for those differences, or just compare outcomes?
I think that ultimately it would be great to sort of, when we have enough people using it and it's out in enough places, it would be great to sort of do a meta-analysis of our findings and sort of look at overall how this program is doing. But I feel like it's a little bit early for that, and so it's sort of a next step.
But you do have a right to keep the data?
Absolutely, we are in touch with everybody who's working on it, for sure.
Tracy, this was a great lead for us to end the series. Thank you so
Great.
much for rescheduling after a snowstorm in
Yes.
March. So, thank you all
My
for
pleasure.
coming. And before we break out, for those of you who want to talk to Tracy a little bit more, she'll be here or out in the lobby. There's the craft fair upstairs on the second floor, the pop-up artisan fair, for a little while. And we are going to be setting up this room for a 3 o'clock meeting, so in about 10 minutes we'll push you on out. But thank you, Tracy.
Thank you.